Primarily northeastern academic type people that I tried to look for somebody who looked like they did clinical neurology, and I couldn't find them.
That's the way all those bureaucracies are. ACGME, the Joint Commission, and they're all self-perpetuating bureaucracies. Just keep looking for more and more reasons to be. They turn into bullies. You know, they try to bully us. We're the ones that gave them their authority. You know, but now they're
Yeah.
Take to the streets.
Now you may have sent it out. I read that statement from the American College of Physicians
I sent that out.
pushing out.
Yeah.
You know, the American Academy of Neurology has not been very protective in regard.
No, the ACP apparently is being very active in opposing.
And I thought their approach was good. It wasn't confrontational. It's just, we got a catastrophe. Let's see if we can't make it better.
That's what I'll tell you a really good book.
Good book?
Yeah, I just read one of the best books I've read in a long time. It's called One Nation. It's by Ben Carson. Do you know who he is?
No.
He was the head of pediatric neurosurgery at Hopkins, and he just retired. And what it is basically is a call for common sense.
Well, it's lost.
Yeah, it is.
It's back to the back.
Okay.
Because they have made faculty that have already left faculty 3 years ago. They all go to
That's kind of wondering if I'm still
Okay. I think we've solved our recording issues. It's our pleasure to introduce Dr. Christopher Newey, who is a candidate for a neuro-ICU position. He's currently a fellow at the University of Chicago in neurocritical care, and prior to that did another fellowship at Cleveland Clinic, where you also did your residency, correct? And so he's a native Oklahoman, so he's right next door to where he grew up, and it's a pleasure to have him back in the South in the heat and humidity, and hope we don't scare him away with all of that. But he's going to talk to us this morning about why we should use continuous EEG, particularly in the neuro-ICU setting. So, Dr. Newey.
Thank you. I was having a hard time with the talk title, or how can I convince you to use the continuous EEG, and what other reasons can we use it besides looking for seizures and status. But we'll also talk about that too, because that's very important with the continuous EEG. But like Dr. Greenfield said, you can never do enough fellowships like I suppose. My wife has wanted me to actually finish pretty soon, so 2 fellowships is enough. But you know, whenever I hear talks, I always remember the pictures from the talks, because everybody brings pictures of where they come from, what they do. The top picture is a picture of the University of Chicago, where I'm at now. I'm on the 8th floor, which is this region right here, and that's my home base. And it has a nice view looking at Chicago downtown. Then below is the new building at the Cleveland Clinic. This is a heart hospital, nothing but heart vascular in this building here. But that's where I did my residency. So I have no disclosures. I think everybody's probably read the objectives, and we'll actually go through a lot of them really quickly. I have a lot of slides, but the one that I did not have on the objective list, because there's only 3 that you can put, is this 4th one. It's just that it's a little project I've been doing recently, looking at neuromuscular blockade in patients with post-synoptic myoclonus and how it affects the EEG and what can use for that. So whenever you have you think about evidence-based medicine, you always think about different approaches. You got the traditional approach. I have a medicine. Is there a large clinical trial saying my medicine's working, it's improving outcomes? But also we have things with procedures. Do patients do better that have got that procedure? And that's something that everybody is always asking about continuous EEG is, they have a procedure, what's the outcome with it? And it's something that will need to be proved at some point, but it's not there yet. But the current thinking is that expertise does matter. And there's a big push right now that you want the best physician, you want the best outcomes, you want patient family satisfaction. And that's something that the neurointensive care unit provides, because there is that voice, that person there at the bedside. So it's really nice from that standpoint. So when you look at the different etiologies across America, across hospitals here, you look at subarachnoid hemorrhages, intracerebral hemorrhages, head trauma, there's a lot of variability. And it ultimately makes sense. The higher volume centers that sees these patients have better outcomes. It just makes sense. You get better at what you do. You get better at treating these patients. The one I always find is that interesting is this intracerebral hemorrhage, and this is something that's been reported quite a bit by Dr. Hempel, is that when you use a frequently used do not resuscitate order, patients do worse. So it makes sense. So it's something he writes about a lot about early DNRs maybe not be in the best interest of the patient. Even though you see a big hemorrhage, maybe the outcomes might not be as good, but early DNRs may not be the way to go. So does a neurointensive care unit actually improve outcomes? And a lot of people have written about this and looked at this, looking at pre-neurointensive care units or neurointensivists versus post-neurointensivists, and looking at different etiologies. And what they found with subarachnoid hemorrhages, intracerebral hemorrhages, is that the higher volume centers have better outcomes, reduces mortality. And maybe with subarachnoid hemorrhages, there's decreased length of stay, and patients have a decreased need for VP shunt. I don't know if y'all spend a lot of time dealing with this, but this is very important for patients. VP shunts do have a lot of complications. You put one in. Every time they come to the ER with a headache, it's got to be the VP shunt. It gets tapped. It's always going to be looked at. So it does have a lot of complications moving forward, and those are just a few of them. And not everybody needs one, and that's something that is very important too. The same with the ischemic stroke and head trauma. Ischemic stroke, maybe shorter ICU length of stays when they go to a neurointensive care unit, and maybe discharge home. I'm not sure about how I feel about that. I firmly believe that if you have an ischemic stroke and you're symptomatic, you have some deficits, rehab is very important for these patients. Head trauma is here, as you can see, is that shorter hospital length of stay, greater odds of being discharged to home or rehab. And the interesting thing I found here is that you have greater improvement in documentation of the Glasgow Coma score. So maybe some documentation actually improves too when you actually are part of a group called a NeuroICU. So whenever you think about an ICU, you think about the evolution, everything evolves through medicine. In the 1850s, it was just this big room, and I'm sorry it's a little blurry, as I borrowed this slide and blew it up a little bit. In the 1850s, you had this big open room, a lot of beds, patients just there, and that's your ICU. Now we have these monitored rooms, single rooms, sometimes with a nice view, window, a lot of toys and stuff in the room as well. In the 1950s, you saw the negative pressure ventilation go into positive pressure ventilation. Some improvements there. So we do have that. 1970s, you start seeing the idea of cardiac telemetry. Back in the late 1800s, early 1900s, this is your cardiac telemetry. Not so portable like it is now, but everything does evolve. And the reason I'm bringing this up is that neuromonitoring is a big part of the ICU, and particularly the NeuroICU. And neuromonitoring is involved in different ways. You think about it in different categories. The clinical part is very, very important. That's probably the most important part of the neuromonitoring. It's like, what is a neurological exam? Patients do fluctuate, knowing what they are now, what they can go, predicting what's going to happen, and acting upon changes that do occur. But there's also a lot of toys, like I've mentioned. Toys being the pressure monitors, flow monitors, anatomical as well with our neural imaging. But a lot of these do overlap with different categories. But the one that's very important to me is the continuous EEG. And partly because that's what I have a strong interest in. And what I find interesting is that when we have a NeuroICU, we have patients in the NeuroICU who are there because they have intracerebral hemorrhage, they have ischemic stroke, they have subarachnoid hemorrhage, but yet we monitor the heart like crazy. We'll have them on telemetry, we monitor respirations, pulse ox, we get EKGs, echoes, but we might get one 20-minute EEG and call it good. So I always find it interesting that, and I know it's just a support issue and just the technical aspects, but back in the day, telemetry, cardiac telemetry was not exactly as easy as it is now. So I think as we move forward that the neuromonitoring with the EEG will be more important, be a little bit more, will be easier to do. At least that's my dream and hope. So there are reasons to get an EEG, and I put cEEG, and that's what we call it in fellowship. It's continuous EEG, and this is what we do. The one that's not just the routine or the 20-minute EEG, but the one that happens hours, days, and so we call it continuous EEG. Some places I believe call it long-term monitoring. I'm not sure what the terminology is here. But reasons to get it, of course, you want to look at seizures, rule out status. You want to characterize spells. Patient comes in convulsing. Well, is it actually epileptic or is it non-epileptic, for example? Syncope. What is the degree of encephalopathy? Is the patient actually in a coma? You can test reactivity. You'll get different EEG patterns. Not all patterns are the same. Maybe they have some predictive value. I'll talk about those later. It can complement neural imaging. Assess the level of sedation, burst suppression. You can also use it to detect ischemia or vasospasm. And a lot of groups do this. And maybe we use it for prognostication as well. So going to the seizures and status standpoint, you want to identify the problem. And this is one of the main reasons why we get a EEG is that, is a patient seizing? Are they in status? I just had a patient in seizure. They're not acting right now. Status is a very frequent neurological emergence, number 2 behind ischemia or stroke. Annual incidence maybe 10 to 40 per 100,000, greatest incidence in the first year of life, and greater than 60 years of age. The definition of status is not as clear as what we may think right now, but it's actually evolved over the course of time. 1960s and 70s, greater than 30 minutes, seizing for 30 minutes, convulsing, that's status. 1990s, the idea was maybe it's not 30 minutes, maybe it's less. Dr. Bleck started talking maybe 20, 30 minutes. Then it started going later 90s, maybe 10 minutes, to the late 90s, maybe 2 to 5 minutes. And right now, 2 to 5 minutes is the current thinking behind what convulsive status would be. So because the reason why we choose these times is that most convulsions last less than 120 seconds. If you go to your EMU, you have a patient seize, it usually aborts within just a few seconds to minutes. If it doesn't, you've got to consider maybe status. So this is a definition that was in one of the PowerPoints I came across in my residency. It said status epilepticus is defined as greater than 5 minutes of continuous seizures or 2 or more discrete seizures between which there's complete recovery of consciousness. And that last part, having frequent seizures without returning to baseline, is very important too. But the one that we don't know a lot about is his nonconvulsive seizures and nonconvulsive status. This is a definition that everybody has their own definition. I had 12 to 15 epileptologists in my residency that I trained with, and every one of them probably had a different definition of what this could be. The one that we use most frequently, the one I use most frequently, is a pattern that has to last 10 seconds. 8 seconds is not a seizure. And one of the following, and the first part's the one that we usually use, is repetitive spikes and sharp waves at least 3 hertz. Of course, if there's some kind of evolution in distribution, it's morphology, location, frequency, I mean, you would consider that seizure as well. But the one that we always came across is this one here. And this is an example, I don't know how well it shows up, oh, great, it shows better here, of having a 3 hertz, just this pattern. And actually, this went on for hours, got kept and went away, so it's interesting. But, or levetiracetam. So there is a whole entire realm of what can be called nonconvulsive seizures, and we don't really have a good definition right now, but it is evolving. There's a lot of talk about it right now. There's actually a group in the American Epilepsy Society trying to get more data and more research on this. So whenever you have a patient seizing, you always want to say, well, the clinical suspicion is very important. So you have to have low suspicion for someone that might be seizing. There's people written about what clinical findings you might find, but I think number one is the one that's probably one of the more important ones, a prolonged postictal state. You have someone that has a seizure, now they're just not acting right. They're very postictal afterwards. It's something you want to think about. Prolonged reduction in alertness from an operative procedure or neurological insult. And that's the part that comes around with the neuro-ICU. Of course, you have the impaired consciousness or fluctuating pictures, impaired mutation, episodic blankly staring, aphasia without acute structural lesions. And that's the other thing is they're not acting right, and they're acting out of proportion with their CT or MRI showing. So keep that in mind too. But your clinical suspicion is not always right, and this is the reason why EEG is so important. Looking at 208 patients admitted to neuro-ICU from an ER with acute transient neurological deficits, loss constants were unclear motor phenomena, they found that 13.9% were diagnosed with epilepsy or seizures in the ER that weren't actually seizures. 15.6% were diagnosed with seizures that were missed or weren't diagnosed with epilepsy. So there's a big group, like 75%, maybe you're correct, but you got this 25% that were just totally misdiagnosed. And it has some different factors for why they misdiagnosed as seizures. And one of them I thought was interesting is the lack of tongue biting. I never really go by that. But you also have to ask yourself, well, I have a patient in the neuro-ICU or some kind of ICU, and they twitch. They have some weird eye movements, or they're moving differently. It has to be a seizure. Let's treat it really aggressively. Well, the other issues we're running into is that not all movements are seizures. And this is an interesting one too I found, is that looking at 52 video EEGs over 18 months in a neuro-ICU, they're found with the diagnosis of possible seizure rollout. So the EEGs were done that way. 27% were actually right. 27% were actually seizing. But the 73% were having some movements that were not epileptic, such as like tremor-like movements, multifocal jerks, slow, semi-purposeful movements, or other sort of movements, such as transient eye movements. And this is what I hear all the time in ICUs. Patient look to the left. Well, when maybe their stroke or their ischemia is on the right. Or they have mouth movements or nodding of head. So there's other reasons you get EEGs, but they may not always be epileptic as well. Again, the EEG is very important to diagnose these patients correctly. So I'm going to kind of walk through, with this framework in mind, I'm going to walk through a couple of projects I did during residency. Just kind of show you some interesting data and interesting ideas, and maybe convince you guys that continuous EEG is very important and that we should monitor. So when I looked at an ICU sampling and the Cleveland Clinic, it was a sample from 2009, 2010. I know it's getting kind of late now, but this is what I did in residency. I looked at about 1,123 different patients that were monitored on continuous EEG over the 2-year period here. And what I found is that 215 of them, 19.1% of them, actually had seizures on the EEG. And 92% of these seizures were without any kind of clinical signs, meaning there was no convulsion that you could see. Maybe subtle eye movements that maybe the EEG, the video did not see, but all that was in this broad term, no clinical signs. When we looked at the different etiologies, the etiologies really just across the board were very interesting. Is that the one that was the most interesting one was that the extraaxial tumors, the meningiomas, they were the ones that seemed to have the most frequent seizures. So it was very interesting from our standpoint looking at that. The intraaxial, not so much as the extraaxial, but they were as high as 33%. The remote strokes, a lot more than acute strokes. And when I say stroke, I mean ischemia in this case. Intracerebral hemorrhages, a lot of our subcortical hemorrhages actually were seizing that were not picked, that were in comparison to our lobar. I'm not sure the explanation behind that. I don't know if there's a disconnect between the two, disconnecting the cortex from the subcortical structures. Or we were actually interested in maybe the size maybe matter, but I have not gotten to that part in the research. But a lot of different reasons for people have seizures. And this is all based on, you have 20 people with seizures that out of the 120 with acute stroke, you get the 16.7%. So within that etiology, what percentage were seizing? So kind of give you a frame mind of what patients to think about who could be seizing. And so whenever I hear meningiomas that just came out of the OR resected that are not acting right, one of the first things I think about is seizure because of some of this research I did. And the other interesting etiologies are, you got your CNS infections, but I have started here this metabolic, and it's one that I don't know if you think about it too much or how you think about it, but the liver, kidney failures, or patients with sepsis, and I'll have a slide in a few seconds that actually shows you a little bit more about that, but 11.3% of these patients were actually seizing. These are MICU patients, the medical ICU patients, the ones that maybe don't have a pure neurological deficit or a pure neurological injury to the brain, but more of a systemic injury. And going through it as well, you got epilepsy, of course, multiple sclerosis. These are very bad MS patients that happen to be in the NeuroICU. And convulsions, just NOS. And the one that was seizing with its convulsion NOS was actually a reperfusion injury. And the other 103 of them were all at syncope, none of them were seizing. But so when you look at there's a group in Columbia, the NeuroICU there, they actually have been collecting a lot of data on this as well, and have published on this in 2004. Sorry, not 2004. But what they did is they said, subarachnoid hemorrhage are seizing. 19% of our patients with subarachnoid hemorrhage are seizing. But if you look at ours, we only have 5.9%. I'm not sure if it's just because they monitor more of the severe subarachnoid hemorrhages, more of the worst ones. But overall, the interesting thing is that we got 19.1% of the patients we monitor. They get 19%. So our patient database was about twice the size. Theirs is about half. And we got about the same number, which is very interesting that whenever you look at the whole broad spectrum who you monitor and why you monitor them, you get about 19%. So that's about the goal of finding patients with seizures. So you're going to monitor 80% of patients that are going to be no seizures, but 19% of them will have some sort of seizures. And so I believe when you can't right now you can't monitor everybody at all times throughout the hospital stay, but the goal is to maybe get less than 20% of your monitoring. If you're monitoring and you're getting 50% of the patients I monitor are seizing, maybe you're not monitoring enough. But going back to this etiology of sepsis, when you look at sepsis alone, and from the MICU standpoint, 9 of our 57 patients were seizing, or 15.8%. So just keep in mind, sepsis can be an etiology for seizure. Of course, our migraine syncope were not, and non-epileptic seizures, hopefully were not as well in this case. So when you look at the different, when you should monitor someone, one thing you want to ask yourself is, well, maybe the level of alertness can actually judge or guide how I want to monitor and who I want to monitor. Maybe I don't need to monitor every awake patient because, again, it's that technical support, getting the systems of monitoring everybody. So maybe the person's awake, doesn't need a continuous EEG. So who should I monitor more? And the ones that you may want to monitor more are the stupor coma patients, because the odds are you get closer of the pink bars being no seizures, the blue bars being EEG seizures, the number of patients on the y-axis, is that the odds of finding seizures in these patients increases quite a bit compared to the awake patient. But the next question you ask yourself is, how long do I need to monitor someone? To say, my monitoring, I'm done with my monitoring, it's over, I don't need to monitor anymore, I'm pretty confident they're not seizing. So looking at here, the y-axis, again, being the percent seizures detected, the time is on the x-axis. So starting, when you hook the EEG on at onset, you may find some people seizing. They're in status, and you hook them up, you find them seizing right immediately. After 20 minutes of recording, you might find a seizure later in that 20-minute recording. Maybe they're having an episodic seizure and you happen to catch one. And you're about 40% confident. But it's not until you monitor for about 24 or 40 hours before you're above 90% confident that if they're seizing, I've seen it. And then afterwards, but before that, you still have that, well, that I'm not quite sure, maybe 15, 20% of patients, times I'm going to be missing it. And it's very similar to what the Columbia as well saw when they monitored patients. So 50 to 61% had seizure in the first hour, a little bit more than what we had, but we had about 40%. But then they had 80 to 95% had a seizure in the first 24 hours. So at 24 hours, 80-95% of the patients are going to have some sort of seizure. But in the comatose patients, it's still 80%. So if patients have decreased level of alertness, maybe need to be monitored a little bit longer. And so they actually, when they got to 48 hours, is when they got to confidence up to 98%. They were pretty confident they were catching it. The questions always arise, and it's something that I have not seen the answer to. Is once you find someone's status or someone's seizing, and you treat it, how long do you need to monitor afterwards? Say they're not going to, not to revert back. So I think we all have our own experiences, our own ways of doing it, but I don't know if anybody's actually looked at that. One thing you want to ask yourself is, what about outcomes? So I have a patient that has seizures. They're with clinical signs, without clinical signs. What are their outcomes? Is it actually doing any damage? And what are the outcomes of patients that are monitored? This is a big question. And one of the questions I hear a lot is, so EEG has yet to improve outcomes. Well, the counter argument is, you have a CT scan, and the CT scan does not improve outcomes. You get the data, and how do you act on the data is really what is going to change outcomes. So the question is, does status epilepticus cause neuronal damage? And there's a lot of talk about that, and this is a brief little statement. So we have an increased intracellular brain glutamate exceeding the excited concentration, causing excitotoxic swelling. You get hypoxia, acidosis, hypoglycemia, eventually leading to neuronal damage. Just really brief. But some people actually looked at, if you have different etiologies and you're seizing, what actually does happen? This one right here from the UCLA group, looking at intracerebral hemorrhages and patients with seizures, what happens? And what they found is that in their 109 patients that went EEG, 76% of them had EEG-only seizures out of the ones that had seizures. And ones that had seizures actually had worse NIH scales, and they had an increase in midline shift, quite significant. And so maybe there is something else going on, or maybe the seizure is just a reflection of how bad the brain is. It's also the question too, but maybe there is something to be said about seizures and what the outcomes will be and what kind of damage occurs. And here's something that I hear quoted quite a bit, and this is really one of the only articles that says, does it actually cause neuronal damage? And it's based on neuron-specific analyses drawn in 31 patients at 1, 2, 3, and 7 days after status epilepticus. It's a mixed patient population from all different etiologies, so keep that in mind. And what they found is that it was elevated in complex partial seizures, absent status, generalized convulsive status, and even non-convulsive status. And what they found is that it was the highest in non-convulsive status patients, lowest in the controls, of course, in generalized convulsions. So whether or not the non-convulsions actually cause an increase in neuron-specific analysis, or is the underlying etiology causing the non-convulsive status might be the reason why they have the increased NSE. It was not really addressed, but maybe there is something to be said with this as well. But this is one of the best things we have right now to say maybe status epilepticus does cause neuronal damage. But we all know that neuronal loss does occur in status epilepticus because of the neocortex, hippocampus, thalamus, cerebellum, and amygdala. And not just status epilepticus, but multiple seizures. And we see this all the time in our epilepsy patients. And here's a patient I had when I was a resident. He came in, a young guy, came in completely healthy, but he came in status. And we got an MRI emission. We actually got a lot more MRIs than what you see here, but at 2 months later, this is what his brain started looking like. He was treated with the status, but he was in status for so long initially that maybe something happened that eventually saw the cerebral atrophy. So I don't know if you see the soul study is quite remarkably different between the two. But he was treated pretty aggressively when he first came in, but something happened, so maybe the delayed effect here. So there is something to be said about status epilepticus causing neuronal damage. Going back to the database that I collected is that when you have seizures on EEG, you have yes and no. The majority of patients with seizures were going to be discharged to rehab or they expired. And again, that pretty much reflects the patient population you're monitoring. People that have seizures maybe have worse brain injury at the time, because these are the ICU EEG patients. So maybe that has the seizures are a reflection of the underlying pathology why the patient's being monitored or in the hospital. So this leads into another project, and you find different patterns on the EEG. Well, you have a pattern on the EEG, seizure, yes, no, you treat it. But what about the non-seizure patterns? For example, PLEDs, periodic lateralized epileptiform discharges. Kind of an old terminology. There's a big push right now to get rid of the PLEDs part and call it lateralized periodic discharges. But if you do have PLEDs on the EEG, can they be predictive, or can you use that as something? And other things you could look at is maybe burst suppression. Maybe the different bursts can say something. But one of the projects I was interested in was PLEDs, and can they predict who will seize? Well, PLEDs is an old terminology termed in 1964 by Chattering as unilateral or focal spikes of sharp waves occurring at 1 to 2 per second. As you can see here, these little discharges just go marching along. And he found a lot of different etiologies why people did have PLEDs, and most of the time it's like a subacute or structural injury of some sort. Maybe from ICH, subdural hematoma, or ischemic stroke are the most likely or most common causes or etiologies that we're seeing in this paper here by Ryer. But others are tumor, abscesses, infections, demyelinating, anoxia, and trauma. And when you see the PLEDs, well, maybe they occur acutely, but a lot of times they'll resolve over a few weeks. There's always a question, how aggressively should you treat PLEDs? And I'm not going to get into that today, but they sometimes do resolve, and sometimes they can be chronic. No one really knows the mechanism of what causes PLEDs. There's been a lot of different proposals, a lot of older data regarding this. There was a lot of research back in the 1960s on it, where they would take the cats, decorticate them, and they have PLEDs, and maybe that's the reason for it. But ultimately, we don't really know what causes it, but there's a lot of different thoughts. Maybe it's a disconnect or another etiology. And no one knows why are they periodic? Why are they occurring marching along? So the trigger site's really unknown. But one thing that Ryer did in 1991 is that he looked at the PLEDs, and you hear a lot of times, you hear PLEDs proper, PLEDs plus, and this is a terminology that's used all throughout the literature, and you'll hear a lot in the epilepsy realm as well. And that he classified them as PLEDs plus. You have your periodic lateralized epileptiform discharges just marching along, and nothing really else scary about it. But then he termed this other thing called PLEDs plus. But PLEDs plus having, you can see here, you got your PLEDs marching along, but you also see this like beta activity overriding it. Or you have it marching along and you just had loss of that interburst interval. The interburst interval being in this section right here. So all of a sudden you have PLEDs just shoot fire pretty repetitively. And so he termed that as PLEDs plus. And interestingly, the thing with this research is that it was mainly done on patients who got their 20, 30-minute EEGs, maybe an hour or a few hours, and stopped. But now that we have continuous EEGs, a lot of things have changed, and it is kind of interesting to take this, maybe the patient had PLEDs plus on the EEG directions seizing, and you just caught it at certain times. But one thing he did notice is that when you have PLEDs plus and PLEDs proper, 74% of patients with PLEDs plus actually were seizing, whereas 5.9% with PLEDs proper, the ones that are just your PLEDs with nothing scary about it, just a little sharp wave looking discharge, only 5.9% actually ever had seizures. So when you look at the Columbia article again from 2004, and maybe PLEDs do tell something, and what they found is that patients with PLEDs, I have it highlighted in this box here, actually had a delayed time to first seizure. So when you look at seizures on the EEG, so with PLEDs, 44 patients had that, but out of those 44, a lot of patients actually had delayed seizures. So when you look at patients who had seizures after 24 hours, 14 of them did. And within those 14, 9 of them actually had PLEDs. So 64% of patients who had seizures that weren't seen in the first 24 hours on the EEG had PLEDs. So out of those patients, 9 of them actually had PLEDs on it. So maybe PLEDs actually may say, well, there's a risk for seizures, but maybe the risk maybe a little delayed. Maybe you won't see it initially in the first 24 hours. So maybe PLEDs can be a little predictive of delayed onset of seizures or predictive seizures. So one thing that I was kind of interested in is that looking at a different database of different patients more recently, 2012, I looked at the first 100 patients with PLEDs in the hospital. And what I found is that the most likely etiology of the PLEDs is that stroke, when I say stroke, again, ischemia in this case, acute or remote, or hemorrhagic, ICH, subarachnoid, or in this case, I just threw subdurals in here too, in the hemorrhage category. And these are the most likely etiologies for patients who have PLEDs. And looking at those patients, you have 55% of them actually had seizures. So, and out of those 55%, 51 of them did not have any kind of clinical signs, or 94% of those 55 did not have clinical signs with their seizures. So you have the PLEDs, 55% of them had seizures at some point, with the majority of them without any clinical signs. But again, looking at when the first seizure occurred, there was a delay. So maybe PLEDs do say something. So what I wanted to do at this point is looked at the way the PLEDs looked on the EEG, and is there any way that they can be predictive of how they look, of who's going to seize? And so right here, looking at different patterns of the PLEDs, you got the polymorphic delta pattern, this little blunted pattern here, just marching along. The overlying fast pattern, you see it here, this little beta, sharply contoured this very sharp way, or rhythmicity, you start losing the interval between the PLEDs. And are those able to predict anybody who will seize? So taking those patients, what we did find is that a lot of the patients did have seizures, and when I looked at them a little bit more closely, is that patients with rhythmicities, that loss of the inverse interval, actually the most likely to have some sort of seizure, and that makes sense. If you have your PLEDs marching along, then all of a sudden it starts speeding up, or you lose that inverse interval, hits at 10 seconds, you got your seizure. So it makes sense that the rhythmicity is one, maybe a little bit of predictive. So you start seeing that, maybe you should monitor them a little bit longer, have your eye out a little bit more. But the polymorphic delta are least likely to have seizures. And maybe it's just the end phase of PLEDs. So you got your overlying, you got your sharply contoured PLEDs, and it starts burning out. Eventually you get polymorphic delta, and you just get your delta patterns without the PLEDs. So maybe this can guide as well, like who should we monitor a little bit more. So again, the interval is the most likely out of all the PLED patterns of who will seize, and it's a lot more than polymorphic delta. Average time is delayed, so about 46 hours in our case here. And a lot of different etiologies can be seen, and most likely ones are the strokes, the ischemic and the hemorrhagic. So we have other findings on EEG, and one thing, just one slide here is just looking at your Coma encephalopathy and what you can find on EEG. And just for, just to let you know, you can look at reactivity, you look at your different patterns, maybe some things are better than others. Maybe a patient who's starting to make sleep structures now or waking up or actually maybe a little better outcomes. How they react on the EEG is very important too. And so I think it's very important to look at everything on the EEG as well. But the EEG is very important for cerebral blood flow. And Dr. Jordan actually written quite a bit on this in the 1990s. And he sent me the slide when I asked him when I was in residency. But again, when your cerebral blood flow is up in the normal range, you have normal frequencies, but again, you start losing the faster frequencies, eventually get to your delta slowing, and eventually loss of all your frequencies when it gets pretty decreased blood flow. And here's just an example just to illustrate that why the EEG is very important with neural monitoring, for example, in like ischemia or vasospasm, and it's based on a lot of cerebral blood flow data. Here's this gentleman who's just kind of slow, CHF. They had, ultimate status for the EEG. And all of a sudden it starts getting slower. This is a 15-second epochs here. And so every 15 seconds it's just getting slower and slower and slower, and eventually CPR started. But it gives you an idea, like just showing like when your cerebral blood flow does decrease, it does affect the EEG quite a bit. And just 1 minute goes from slowing to flat. So it is very sensitive. So one last project, and then we'll have some time for questions that I want to talk about. This is something I've been doing a little bit in Chicago. Is when you have a patient, you're called for prognostication, you're like, okay, I'm gonna get the EEG on this patient, just kind of cardiac arrest, it's got myoclonus, we'll get the EEG, see what it shows. But sometimes you get that EEG and you're like, I cannot interpret this, it's just totally artifact. And that's something that I was kind of wondering, and well, so is it worth, is it worth monitoring someone for 24 hours if you just cannot read for 24 hours and knowing what's going on? Is it really good for the patient and the whole entire system as well? So one thing I was kind of wondering about is what can you do about it? So again, myoclonus and generalized periodic discharges have been associated with poor outcomes, and this is well described. And recently, the group from Columbia in 2012 talked about this a little bit more, looking at their data. And I kind of wondered what kind of patterns you can see under the EEG in patients that you cannot really interpret, or ones that you think you're interpreting correctly. Is it fully correct? Because if you have patients at cardiac arrest and actually they're seizing status, well, just changing the seizures, treating that, improve outcomes, and that's something we don't really know, or is it just a reflection of the sick state as well? So what I did, I looked at a few patients here, 9 patients, and different etiologies, past medical history, but the type of arrest, most of them are PA arrests or asystole versus VFib, VTAC arrests. And what I saw here is that we hook up the EEG and you get patterns like this, or you get patterns like this, or patterns like this. And, well, that's you're hooking them up. Well, does that help you if you have this for 24 hours and you want to know what's going underlying all this EEG? Well, what we're finding is that if you give them a little bit of neuromuscular blockade with cisatric chironium, you get improvement. You take out the EMG artifact, and perhaps you see the underlying rhythms a little bit better, as you can see here. And so maybe it can be helpful, and maybe within like an hour of recording, you already got your answer, what you want to tell the primary team as well. And maybe it helps with reading the EEGs, because someone you just say, I cannot read it, it's just artifact, and I cannot interpret it, but maybe it doesn't help with it. And gives an answer to people that they want a little bit faster. So just moving along here, and overall, expertise does matter. Neurocritical care units have been shown to improve outcomes. And this is, again, I think every month there's like a new article that comes out saying, well, before and after, what's happening with our length of stays or outcomes. So there's something to be said with it. Admitting etiologists to the neurocritical care unit do have varying degrees of seizure incidence. So maybe you're a patient with a meningioma or remote stroke or remote ischemia actually might have a little bit higher incidence of seizing than the acute ischemia. So you have to keep in mind that etiologists do matter when you do look at these patients. And also keep in mind that there are other reasons for people to be seizing. In a sick state such as acute liver failure, sepsis, or other reasons for you to think about seizures. Neuromonitoring is an evolving concept, and it can be useful in other ICU questions, such as diagnosis and prediction of seizures. That's what we always want. That's what our main goal is. But what's the degree of encephalopathy or coma? How are they reactive? Do they have sleep states? Maybe prognosticating as well. So there's a lot of areas for the continuous EEG, and these are just some of the things that are coming out that I was thinking about when I was thinking about like future areas of research. And there's so many questions you can ask. But the one that I was talking to Dr. Greenfield about a little bit is say, can the EEG be used to guide medical therapy in the neurocritical care unit? For example, can you use an EEG if it's so sensitive to blood flow, and someone all of a sudden has normal rhythms that's going slow all of a sudden, who's being monitored for subarachnoid hemorrhage, vasospasm, well, maybe that's an indication that there's some ischemia or some kind of decreased blood flow occurring. So maybe that's their time to provide hypertensive therapy, and if you got your hypertensive therapy and you got normal rhythms again, maybe it's working. Maybe you've actually done something. Maybe EEG can be used to guide medical therapy. Some question to ask or look at some point. But there's a lot of reasons, there are a lot of things to look at. And one other thing I was interested in residency was the newer anti-epileptics, and it's not so new now, but it was pretty new when I started. It's this drug called lacosamide in treating status. I actually had a lot of data on that as well, but I did not present here. But there's all these new medicines too, but every one of them has mega role for seizures in the hospital, and ultimately we just need more IV medicines, and that's the big downfall with a lot ICU. I do have to give thanks to a lot of people here. Dr. Stephen Hantis, who was at the Cleveland Clinic. He was the mentor for all of my projects there, and he really helped me out so much with a lot of my EEG as well as in my epilepsy fellowship. Donna was a tech there. She helped with a lot of data collection as well. Time to first seizures she helped with. And the rest of them are neurointensivists. Dr. Artie Sarwell, she's at Wake Forest. Jeff Frank, Alejandro Hornig, Mazion Gershon, and Anise Ardelt have been very influential with just a lot of my neuro ICU training and ideas. There's a lot of references if anybody's interested. So I've looked at it pretty quickly because I knew I had a lot of slides, but I also was asked to have some time for questions, and I thought that now would be a good time to do that. So, if you have any questions?
So a couple of, one, the transition from PLEDs to seizures is a really interesting problem because it's often hard to know whether the patient's in the process of improving because you start to sort of fill in the less continuous pattern where there's suppression between the PLED discharges. And so you've got a short stretch of more rhythmic activity, and the question is that a seizure trying to happen, or is this trying to improve, and you're starting to have other rhythms pick up? And that really depends on the nature of that rhythmicity, and is it evolving? And the problem is typically that you don't have very much to look at because it's 4 or 6 seconds, and so it might be really interesting to look at, what happens in those rhythms in that, and is there a way to look at those bursts and analyze them in the context of what's going to happen later? Are they going to develop seizures, or is this something that's in the process of getting better? And is there a difference in that rhythmicity in those little bursts that you could be able to sort out? Because that becomes really hard to know when you're just looking at that burst in isolation. The other question I had for you is what comes up very often in post-hypoxic patients who are put on hypothermic protocols. Are you doing very much of that there? And have you been monitoring those patients? What kind of things are you doing with that?
Hypothermia is going through a new phase right now. So I don't know if you're aware. In November last year, there's this new article that came out
with the 33 versus
36. So
36.
maybe it's not so much hypothermia is actually improving outcomes.
Yeah.
Maybe it's just preventing fevers. And
that's so people backed off at your institution for doing what?
Yeah. So the Dr. Cole team is what we call them. The team that comes in and says, "I'm going to start hypothermia." Well, now it's just we're coming in preventing fevers. So because that's actually, and I think the American AHA, from my understanding, may be going through some. Because they're actually going to start changing their guidelines, I think, next year, next time they meet. So it might actually be evolving as well. But whenever, before November, if there were hypothermia, I always wanted EEG. Because that's really one of your neural exams. Because a lot of times there was so much sedation at that point for the shivering and other etiologies. So the EEG to me was very important at that point. But now with everything else, we don't have to monitor as much for the hypothermia. I think I've seen only a few hypothermias now in the last few months.
You made a very, very good point that patients with metabolic states, sepsis, hepatic encephalopathy have seizures. I mean, we get EEGs, but we generally don't see seizures, we see slowing. Mm-hmm. But if we were to have them continuously, then we would catch stuff. Now, then let's go one step further. Can we improve their mental status with anti-epileptics then? Or is there any data to suggest that?
Yeah, that's the big question is, when you have this data and you have seizures or whatnot, well, does it improve? So if you have a seizure, someone's seizing, of course you want to start, because it's hard to watch someone seize without treating it. But, so it's a good question. So are you asking if you have someone that has slowing, if you treat them with anti-epileptic, does they get better? Is that your question?
No, I think what the point that you made was that these people eventually, if you monitor them long enough, will have seizures in their monitoring. Okay. So I think, well, then if you see them seize, you give them something like oxazepam, which their hepatic encephalopathy. It's not a liver metabolized. It doesn't have that first-pass liver metabolism. Would you actually improve their mental status? Would you wake them up a little bit?
Yeah.
And if so, then would it be worthwhile to put them on something long term to expedite their recovery from their metabolic encephalopathy?
Yeah. Going back, I guess if anybody has a seizure, my feeling is you should treat it. So I usually, whenever they're hepatic patients, I try to avoid anything that goes to your liver, of course. You always have to wear tubes. They always have some kind of renal insufficiency, or they might have some kind of renal insufficiency. So you have to keep that in mind with some of the renally cleared drugs. But there's also all these endogenous benzos that are created with the hepatic encephalopathy patients. So give them a little benzo on top of their already benzo state, maybe makes them a little worse. So I always try to avoid benzos too. But if they're in status, we put them on a Versed drip and treat it appropriately or aggressively. But it never fails. I mean, we see, for example, I had a consult just recently, a patient who, it was a patient who was pretty yellow, like a highlighter, from hepatic encephalopathy, and so had seizures. So he's on the Keppra. Renal failure is fine, but he hadn't had any more seizures, so I'm assuming maybe it does make a difference. But my thing is, if they're seizing, you catch a seizure. If you don't treat the seizures, they're going to get worse eventually. So maybe it makes a difference. But you always have to weigh the risk and benefits of, does my seizure medicine actually make a person worse? And that's always a big issue with prophylaxis in the ICU. And I hear this debate all the time about, the patient has a subarachnoid hemorrhage, should I put them on anti-epileptic? A lot of people do. Or an ICH, should I put them on anti-epileptic? Well, maybe a temporal lobe ICH means different than a parietal lobe. So there's a big debate like who should be even on anti-epileptics, because there's some data that shows people on dilatant actually may have worse cognitive outcomes when they don't have seizures. So you do have to weigh the risk benefit. But if you catch a seizure, I would treat it.
Well, one of the points here is also that the criteria that you use, the Young's criteria, the last is actually response to anti-seizure drug. I mean, ideally a short-acting benzodiazepine, but that always doesn't happen.
Right.
And you have seen so many patients in ICU already. They're on the spectrum. Things are not clear even when the EEG is used, and you have to kind of say, well, it's very suspicious, and you have to use anti-seizure drugs for a short period of time, maybe 24 hours or so, and the EEG pattern doesn't improve at all, and everything else is wrong, and then you come back and say retrospectively, saying, you know what, this was very suggestive, but I don't think it fits.
Yeah.
As having a seizure. I mean, the drugs have a role, but even then it might not mean that everything that you will treat would result in improvement. Mm-hmm. But at the same point, it needs to be treated.
Right. You always have to weigh the risk benefits of being too aggressive and making a person worse, because there's that problem too.
Just one comment about this is that non-convulsive status and in status, the governing factor of the outcome is the etiology. Of course, you need to treat the seizures, but it does not necessarily change the outcome. If it's a benign etiology, it's going to have benign outcome. Malignant etiology is going to have malignant outcome. And in terms of treating the seizures, it depends, as Kinshuk was saying, on the pattern. I mean, some patterns we are confident they are seizures and they need to be treated. Some patterns, I mean, we're skeptical. We're not sure if they are seizures or not. And sometimes treatment might worsen it if it's really metabolic encephalopathy, and you give them, excessive anti-epileptic medications, and they end up on phenobarbital or something like that. You're going to make it worse. So, it depends on the pattern that you're saying. Always a trial might be beneficial if you're skeptical, but you have to be careful that you're going to might make the situation worse.
I agree.
Do you know if there's any literature on continuous EEG monitoring of eclamptic women?
It's a good question. I don't know about the literature, but I know one of my co-residents, who's actually looking at that. So I'm not sure what she found, but I know she was talking about there's not much out there really that she was doing, but she was working on it with another guy attending. So I'm really not sure. But there's EEG with press and whatnot for eclampsia. it's interesting. So I actually have one of my have a press patient right now that in status.
Oh, really?
Yeah. Yes.
So what's your experience in quantitative EEG monitoring with our hemorrhage, like persist? You know, with people with EEG, they can use spectral analysis to look for alpha delta ratio. What's your experience on that?
So where I'm at now, we have the capabilities, we just don't use it. And what he's talking about is for you all, it's really, you can't really see it up here on the screen, but it's kind of blurred. I do apologize. The persist analysis right here. So what it does, it takes all the different rhythms and it kind of pick your how long you will look at, and it compresses them into like different spectral arrays, a whole bunch of different algorithms and math behind it. But it looks like rhythmicity, it looks like asymmetry, it looks at burst suppression ratio, as well as some alpha delta ratio. And maybe with all that information, you can make a diagnosis. So one of the things, I had a lot of projects in residency. So another project that I was working on before I left was that, is there one part of the persist that does make a difference more than others? And what, because you can't just take rhythmicity alone and say, every time my patient has a rhythmicity pattern that looks like a seizure, that's correct, or I'm very confident that all the rhythmicity is, if it looks normal, is not seizing, because there's going to be other patterns that you might see as well. But in this case, you can see, like, going across the board, seizure here, you're going to see a lot of different changes across all the different variables. But we don't do a lot of it right now. There are some institutions that do, that rely on it heavily. For example, like Mass General uses it very heavily for looking for vasospasm. But I think it kind of depends on like what's your comfort level of looking at it, as well as your support to look at the raw data. Where I train, raw data is very important. We had, it was a very interesting unit where we had someone looking at the EEG at all times, 24 hours. So there's always someone looking at the EEG. So in real time, whereas here you may be looking back in retrospect. But it is a way to actually very quickly look through an ICU EEG if you understand the patterns of very different variables. But no, we don't use it much.
We started using it in our fellowship, and it was turning out to be very useful. But there were several things, and the first thing was that you had to actually know what the patient's seizure looks like on this, because every seizure kind of looks differently. So if you're able to pick out the seizure and on the raw data and then match it, then you'll be very good at picking it up later. Yeah. And certain patient populations, we didn't think it was very reliable, especially neonates. Yeah. Their seizure, and the problem is their seizures change so much that you are picking seizure and you are in a lull that all has disappeared because your pattern has disappeared. But the problem is that there is a new pattern which you are not picking up. Yeah. But it was very useful, especially for showing the team what 24-hour looked like, instead of trying to scroll down like EEG pages and asking them to tilt their heads, squint their eyes, and look at the kittens on the screen. It's so much easier to show them beautiful colors.
Yeah, so what we did in fellowship, in the ICU, we have like the continuous EEG monitor up in the ICU with the raw data, like this snapshot I have up here. So as we walk by every morning, we can actually look at it and say, in the last couple hours it looks okay, so they can ask that question. So we don't have to run back upstairs and keep looking at the raw data, but yeah.
Well, thanks so much. That was really good.
Well, it's nice to see you, Dr. Cole.
Well, I'll keep my score a little bit.
You got to tell me something.
Well, I was just going to comment on your cane.
Oh, yeah.
First off, it isn't cane. It's high tech.
Oh, I wish I was young like you.
I had some photographs made of me, and there was an old man looking back at me. An old filter put on my picture.
Well, when I have a photograph made and I complain, they say, well, that's all we have to work with. By the way, the lady that's funded my picture, we're going to do the governor. Hey, Heather.
My wife said, no.
Well, she was probably up there about a year after the painting is done.
It's actually that. It's
Put
usually
a covering on it that preserves it. Yeah, that's right. And it can be washed.
I did all three. I did the other three first.
Well, younger.
Your bag is one now doing it.
That was original. That was my second time.
I dug, after I saw that, I dug out my bag, but it was given to me by some senior, I guess.
The technology is we can do
Looked at it, it's not beat up at all.
There's also like 20-minute EEGs versus EEGs.
The ones that show,
coming out like
or you can put the grids. I think Elizabeth made some
So we should be okay.
Because there are lots of variability.
That's not your head.
It's not mine, no. I've got one like it in my bag that I haven't used for years. This says Wilcox. No idea who Wilcox is.
Yes.
That's hard to do because having a higher
I'll be ready in 10 minutes. Downward contact.
That's always the issue. Right now, we can also take them off, or we're going to put it back on.
It's not the
He's got like some ICT compatible. So we had one set later on, so I used it. Problem is that
they have like indicators.
so you put some like
Yeah, but
but it wasn't beautiful.
Well, there are ways to do that, I guess. And carbon electric functional MRI.
Did you see my note?
Yesterday, yeah.
Oh, God.
Did she?
She finally came in. What happened was, yeah, so I dismissed her.
Yeah.
And then the day that she got the letter, she called and she was like, I was like, give me another chance. I said, okay, I'll give you another chance. Yeah, and so I gave her one other chance, and she didn't show up. Scheduled her again, knowing that she has radiation appointment. She didn't show up for it either, and on the same day, because I was like panicking.
But I guess, the
And so
main thing is
and so
memory
next,
is such an iffy thing with wires.
after that second no-show, she got her letter certified mail. She called and started panicking, arranged for both my appointment as well as radiation.
Well, how much crossover was there?
She will be seeing him on the 17th next week.
Yes, next week.
But she came and saw you.
Yes.
You met, you saw
Mainly,
Yes.
that's been a function of the fact that we're doing
Oh,
fairly straightforward cases.
And they'll say that.
And doing
Yeah.
selectives.
And she was trying to get me to get her seen.
Yeah, of course.
And I said, I can't do that, because Dr. DeVon's letter says, do not,
Yeah,
note says,
she's a-
do not do anything.
very much.
And so,
Anyway, it was great
I mean,
talk.
I was crying.
Well, let's, you need to make a bathroom break here, and then we can talk a little bit more, and then we'll sort of get you.
Yeah, but I mean, she had to super.
So, this will.
No, she was probably had the oxy and slept on the heating pad.
Go to sleep by
And
itself.
then, what happened was,
I think you're on Dimitri's
Karen
schedule
mentioned it
later,
to me.
he's on your
And
schedule
they
later
tried to get her
today.
in. That's why I was so pissed.
Let's get one.
Yeah.
I mean, there was this big room here, and she wouldn't come in. And we've been trying to get her in, and finally, apparently she saw someone else. Some guy from, I think, I don't know. I looked it up. It was a surgeon, and it says cardiovascular surgeon, but maybe also that's general surgeon. But the room was better. I mean, it's still regulated. There's still a there's things that I think is properly cared for. But I told her, she's got her DOR, she's got the history on us. If you talk to your local doctor, ask him who your local doctor is just here to get your book. Yeah, but I don't know.